Okay, looks like we have a goodly number of folks already joined and continue to join as we speak. And so thank you so much for joining us on today's webinar. We're going to be talking about the Mental Health Parity Index, an exciting tool that we launched with our partners at Third Horizon and the American Medical Association, piloted in Illinois, and we're hoping to expand nationally. I'm Nathaniel, as I said, Chief Policy Officer of the Kennedy Forum. And to launch us off and give some opening remarks, we're going to hear from our founder, Congressman Patrick Kennedy.
Thank you so much, Nathaniel, and you've been so incredibly diligent about moving forward the whole fight for parity, which, as everyone knows, just as a historical um, context, effort to try to ensure that payers pay as much attention, pay as much money for mental health and addiction medical services as they do other physical conditions. And it has been really the lever by which we in the mental health and addiction community can now fight for the resources we need to ensure that we address this problem. But it was the beginning of a journey. I can recall when my Republican co-sponsor, Jim Ramstad, and I went around the country with Mental Health America to do hearings, that we were hearing from families who not only had trouble getting access to treatment for their loved ones, but also access to quality care. So that has now become a big part of our fight for equity. As you know, there's very little translation of evidence-based interventions in the treatment of these illnesses. And of course, most importantly, there's very little integration of mental health and addiction in overall management of chronic illnesses. And that's where we come today. I want to thank Third Horizon for really taking the lead on this, because they've done the important work of addressing the unsexy part of this fight, which is how do we use data to advance more access to care and the right kind of care. And so really the fight for parity has been, first, the quantitative treatment limits. We had to make sure there was no higher copays, higher deductibles, higher premiums, lower lifetime caps. And then we moved into the non-quantitative treatment limits. And those are really the data points that Third Horizon's been able to really suss out for us, so that we can get to medical management practices, we can get to network adequacy, we can identify what a person has to do in order to get the health care they need for their loved one, and how it compares to other medical conditions. We can talk till we're blue in the face, but if we don't have that data, often we get dismissed. And thanks to Third Horizon and all the work that they've done, I want to thank David and Greg so much and the whole team there for what they've done with this initiative in Illinois, which we really believe is kind of a template for what we hope to roll out nationwide, especially now in the new administration, where we have some challenges, but we also have some opportunities. The challenges are, of course, they pulled the latest parity rule that Kennedy Forum is very instrumental in helping to write and push for. And that, while that was a huge challenge and disappointment, on the upside, they have been stressing transparency rules. There was a law that Trump did in his first administration, and now executive order doubling down on. They are very strong behind examining all the aspects of payment. And so that, frankly, gets us to the same place really our parity rule had intended to go, and that was to get kind of a forensic audit of payers, and to understand really where there might be disparities. Thanks to the broad transparency rules, we can get to those same findings. And in fact, we believe that with AI married to this template that Third Horizon has put together, we could almost bypass a lot of regulation and get right to the facts, man, as they said. Just give me the facts because the facts will tell the story. And what's important for policymakers is it will also help, as we heard in Illinois, those decision makers to allocate resources in the places where there's the greatest deserts of access. And that will be important for equity as well to bring mental health to underserved communities. So, really, this whole initiative is about building a framework, utilizing these transparency rules and the law to try to really advance this space. And so I really want to thank, again, the partnership we have with many of you who are on this webinar, and also look forward to this whole effort going forward. I think it's easy to see that with the huge changes in not only policy relates to parity, but also the impact of how do we integrate mental health, not just as something separate for those with primary diagnosis, but to really understand the value of mental health to the overall health and well-being of people with other physical illnesses, other chronic illnesses. This will help us as we move into the value-based contracting space, which we have never really been part of, but frankly, where mental health probably has the greatest opportunity to increase reimbursement for providers, understanding that if that value is demonstrated in the data, which we believe with supportive AI decision support, clinicians are going to be able to bring the latest in evidence-based interventions to their patients in a uniform way without the kind of vagaries of geography and training and classification and license that often takes place with the delivery of mental health care. We really think we can get to a place like other illnesses where there's standard protocols and treatments and outcomes. And of course, that has been the goal of the Kennedy Forum, is to establish this 90-90-90 by 2033, which we really perhaps have a chance to make even greater progress with in a shorter amount of time than we ever imagined. It's 90% of Americans should be screened, just like we do with cancer, diabetes, and other issues. 90% should be getting evidence-based treatments, which is what we expect for other illnesses, and 90% should be supported in their recovery. With that as kind of a lodestar for our movement, now we've got to understand where we are, where the gaps are, and where those gaps need to be filled in and by whom. So lots to unpack here, but I know with Nathaniel's leadership, we'll get a lot of the questions started. Maybe not all the answers throughout this webinar, but I hope it's the beginning of a conversation we have on an ongoing basis. So I'll turn it back to you. Thanks so much, Nathaniel.
Thank you so much, Patrick. We really appreciate your motivating words, and for starting off Parity in the first place. And so in a second, I'll dive into the actual tool itself, and I want to just sort of give more context and prep for the power of this tool. So as Patrick said, in 2020, with like I think shocking little fanfare, President Trump put into a rule saying that all health insurance companies had to post publicly all of their negotiated rates for every single service, for every single provider, for every single product. Um, and is in these things called machine readable files. And the magnitude of what these are is enormous. I think the total file size across all of them is beyond terabytes. It's in like petabytes. Uh, Even trying to look at like a single file is kind of looking like a solar eclipse. Like it's just like impossible to really get into it and see any of these details. And so the magnitude of this data analysis is beyond profound. It's now, I think in 2022 is fully implemented. And this is, to the best of my knowledge, really the first use case using this transparency and coverage data that's been out there now for several years for any kind of decision making, especially in mental health and substance use. So we think this is really exciting, and this Illinois pilot we're hoping can really start off something across the country. And so then, with little further ado, I want to put in the chat so people have it, the link so you can access it anytime. And then I'll share screen and share the tool with you all. So I just wanted to start with the landing page just as a good place because this gives sort of the full explanation of the context of it. Um, and then like, the whole background on the Kennedy Forum, what the measures are, and then disclaimers. And then also the wonderful groups that helped. This wasn't just us alone deciding what should go in and what shouldn't, but we got incredibly detailed feedback from thoughtful partners about um, how to design this tool. And so we were really appreciative of it. And so with that, I will go ahead and launch the actual index itself. Um, and so here you see the first view, and I'll click away so you can kind of see the full magic of it. So here we have our map of Illinois, and you'll see we have these three indices. This is network composition, outpatient professional reimbursement, and inpatient acute reimbursement. And I'll start with network composition as a first index. And so what we have here for both the whole state view over here and then for each county is you can see here's the total number. If you look in this, like in the left-hand box that just popped up, here's the total number of registered licensed physical health providers, and then the total number of licensed mental health and substance use providers in that county. And so what this index calculates then is going through all of the data we just mentioned, what proportion of those available providers that are registered are in network with a health insurance plan in that county and are not. And so you can see we're just going to stick with Iroquois County for this example. There's 156 licensed physical health providers, and 73% of them are in network. And then we have 206 licensed mental health and substance use providers, and only 34.5% of them are in network. And so that leads to a percent difference of 72.6% of the disparity between physical health providers in network and mental health and substance use providers in a network. And so this kind of gives like there's always been this question of what is sort of like the root cause problem here? And there's an issue like, is it how many people are network? Is it reimbursement rates? Is it the total number of providers available? And so what this begins to show is that there does at least appear to be quite a few number of registered providers, but fewer are coming into or part of the networks on the mental health and substance use side than the physical health side. So it's not just an issue of the sheer number of providers available. And so it's sort of like a fascinating finding that I don't know that anybody going to this project fully expected to find. And so you can do this county by county and look at, and you'll see it's sort of color coded. So one interesting thing you'll see is that here in Piatt County, it's a pretty small number of providers, but you'll see there's actually more mental health and substance use providers of proportionally in network than physical health providers. So this one actually happens to be above parity. But then in other places you see, I mean, sometimes there's no providers at all, so you get this dark, dark red. But sometimes you also see there's like 104 licensed providers here, but only 10% of them are in network, whereas 70% of the physical health providers are in network. So you'll see like quite a lot of variation across the state, and often these are more rural counties too. So it sort of as this double hit to Patrick's point about geographical variation of not only are there fewer providers in some counties, but even fewer in network proportionally. And then on the right-hand side, you can see across different health insurance plans. You can see next and see all of them. And so these are the sort of like a representative sampling of 8 different plans. So we have like the Aetna, several of the Blues plans, Centene, United, Cigna. And so, and for each, it kind of shows, I'll just go with this first one, uh, across the plan for the entire state, what percentage of physical health providers are in network versus mental health and substance use providers. And so you can see the differences, there's differences across at different levels. So almost all of them have some level of difference, but the magnitudes vary across each. And one thing that's interesting is we don't, it's not like every provider out there would be in a network. And some of them, have are registered providers but aren't practicing right now, let's say. And then some are practicing but might not want to come into a network for a variety of reasons. But so one thing that makes this is interesting about this is you can see that at least one plan was able to get about 51% of the providers into any network. And so we know that, there's a lot of variation here, but we know that a goodly percentage of the providers will join a network when offered. And so that's sort of another interesting data point we have access to as well. Some other interesting functionality of the tool is you can set up different comparisons. So you can look at 2 different counties. There's just a lot of different exciting options with how we look at network composition. Um, And then also just as we go too, if you have questions, please go ahead and put them into the chat. We'll do a Q&A later with the full group. But we'd love to just start getting your questions as we go because it'll be hard to remember as we get into it. Okay, so that was this network composition index. That was the first one, and that's just looking at the proportion of providers, physical health versus mental health and substance use that are in network out of the total available. This view is different. This looks now of the contracted rates for all these services for physical health providers on one hand and mental health and substance use providers on the other hand. Um, what is sort of like the relative rate for each side? And so one challenge you face like right away, right, is like how do you compare the ways that physical health providers are paid for their services, which might look quite different than the way that mental health and substance use providers, like the services they're providing are different. So how do you make a comparison? And so the strategy we use for this is the American Medical Association created the system called relative value units. And basically what it does is quantify like across all sorts of different tasks, whether it's just like, seeing a new patient or doing a dermatological procedure or doing 60-minute psychotherapy across all of these different things. It looks at how much sort of like work and effort and training went into it, how long does it take, how much expense goes into it, like what sort of like machines do you need available, how do you have to have your practice set up, what is the malpractice liability associated, and it puts all these different components into a single value so that you can have kind of like an apples to apples comparison across all sorts of different activities. And so we sort of pared it down a little bit more to activities. We took out like sort of surgical procedures from this. So we got even a little more apples to apples. And so we compared basically the price that services are paid for a physical health provider per unit of work to the price that mental health and substance use providers are paid for a range of services per unit of work. And so this allows for a sort of much more direct comparison. And it's the same way that all of Medicare is paid, basically. Medicare use these units of work and then just adds on a certain dollar conversion on top. So it's a fair system that is used extremely widely in this country. The other little bit we did is the way that the it's set up is so that we have like a lot of different services that every single provider provides. Um, but they don't provide them all the same amount. So they might do a lot of just like normal, like seeing a new patient or a repeat visit in office, but much less, let's say, like transcranial magnetic stimulation. But they might still have the code for that. And so to make up for the fact that people are billing differently for different amounts of things, we also weighted it a bit. So if you do a lot of one service, that counts more in this equation than if you don't do any of that service at all, using claims data. And so what this then does is it looks at like let's so here's an example with one of the plans. For physical health providers, we have that pays on average $55 per unit of work versus a mental health and substance use that pays about $41 per unit of work. And so we see different like levels of disparity or similarity across the different plans. I'll just kind of click through so you can see it all. And different amounts. And so it's interesting. So some are quite similar, some are quite different. Um, and there's some variation across counties, although it's much less dramatic. The ones that are deep red, I think, are all the ones that have no mental health or substance use providers. But uh, there is variation across counties, but the level of variation is not so extreme, it seems, based on the colors. Um, there is just overall sort of like across the entire state differences is what we see. And so kind of one of the interesting things is when you combine these two facts, that there's a lot of providers who aren't in a network, this begins to set up a potential reason is that there's uh, mental health and substance use services don't pay as well when you're in network compared to physical health. And that could in part explain some of the disparities that we see. So I'll move on to inpatient acute reimbursement index. And so this now looks for uh, the way that hospitals are paid. And so this includes due to the way that sort of like hospitals bill um, psych units that are inside of larger hospitals. This does not include freestanding psychiatric facilities or children's hospitals or residential treatment centers. Basically, one of the challenges we found is that the way that those are paid is very, very different, and we are still looking for a way to sort of like add them into this system. But what this looks at is similar to the way that the physician services are valued. There's a similar way that hospital payments are valued. And so we looked at per unit, this is called DRGs, per like sort of admission. How much does it pay for physical health admissions per DRG versus mental health and substance use admissions per DRG? And the interesting thing is when you just look at overall, they are quite similar. And sort of asking around, what was found is that hospitals tend to just like negotiate an overall price per DRG rather than looking at each individual. And so you see there's pretty good parity throughout. Some places I think where there actually isn't any, or there's like quite poor for some reason or another. But we have a lot of green patches. Although this it changes a little bit. One thing that um, Greg and the team found was they were looking into this a little bit more, is that um, if you then factor in though how many days people to the length of stay, like how many days people tend to actually be in the hospital um, for these payments on mental health and substance use for physical health, we found that actually the physical health payments are taking into account um, a shorter length of, or like allow for more sort of like longer length of stay than the mental health and substance use services. So even though they were paying similar amounts, the mental health and substance use stays actually tended to be quite a lot longer. And so when you look at the payment per day in the hospital, then you start to see some potential disparities emerging. And so that could come in part from the way that lengths of stay have changed over time versus the initial way it was valued. But it does seem to be that there's a disparity that emerges when you look more heavily into these. Oh, and then one thing I also just wanted to highlight back up here with facilities is so you can look at also the percentage of individual providers that are in network um, out of the total, and then also facilities in network out of the total. And so that begins to set up some of the key sort of dynamics you can look at in the tool. And then I wanted to go back to this. So now that you've kind of got a sense of what the tool itself is and what it does, I wanted to show you some of the sort of like higher level things that you can read about. So this just gives an about, and this gives you more details about how to sort of use the index. And we even have a detailed how to use guide. So when you try this on your own without me talking over it, you could still find your way. And then I also especially want to draw attention to the key findings. So what we find is that basically like when you average across these plans and the proportion of the population they cover, you find it's about a 55% difference between the percentage of physical health providers in network versus mental health and substance use providers. So that's like the overall amount of disparity, which it goes from, you can see like the relative ranges across the state. And then for the overall physician professional services reimbursement, it's about a 27% difference between physical health and the mental health and substance use on the other side. And it's about twice as much when you calculate out the length of stay for hospitals, and almost a parity if you don't consider that. I also wanted to make sure that people saw, if you want to read more, we have an incredibly detailed methodology document replete with wonderful equations that you can really dig into and see how we did some of the weighting, how we did the normalization, and really see for yourself how some of the background math works. And then also, if you want to see how we classified like a mental health versus substance use provider versus a physical health provider, which services we include and didn't, things like that, that you can find all of that here. We also have a helpful glossary of terms just to make sure that you can see how some of these things work, like the relative value unit, and really get an understanding of it. DRGs are explained, um, and then just contact. So you can always reach out to info@kennedyforum.org. And with that, I will stop the screen sharing and I will welcome in our wonderful panel to discuss that a bit forward. Let me add the rest of them to this group. Welcome. So these are our, representatives of our wonderful partners at Third Horizons and AMA who helped make all of this possible. Um, and maybe just to start, if you want to go around and we can do introduce yourselves and then what brought you to this project? What made you really excited to get started in all of this and make this come to life? And I'll start with you, Greg.
Yeah, well, thank you, Nathaniel. It's great to be on with everybody, and thanks for walking folks through the tool. It's an exciting moment to kind of be sharing this work that we've been involved in for a year and a half. I think obviously for those that don't know, I'm a person in long-term recovery, and mental health and addiction care is near and dear to my heart, and improving the delivery system. I think to answer your question directly, Nathaniel, I once tried to consume inpatient treatment and mental health services. And my family was thrust with the decision of paying exorbitant out-of-network costs to receive that treatment. And so many people even increasingly in recent years are paying high out-of-network costs. So as Patrick said, we have done a really good job. That the plan book reads at parity now, which was no small feat, and amazing kudos to all the advocates and regulators who've gotten us to that place. But today, in reality, unfortunately, individuals with commercial health insurance um, are just paying more for mental health and substance use, primarily because of this out-of-network issue. Um, and so once we got into these transparency files, which David could talk a little bit more about, we started to explore the possible use cases, and we needed experts at the AMA and the Kennedy Forum and others to get into it. But we're really excited about the possibility of this data, and really a way to look at parity through a brand new quantitative lens that we've never been able to do before.
Absolutely. Thank you so much. I'll turn to you, David.
Yeah, Nathaniel, thank you. And Patrick, thanks for your remarks. And we feel so similarly about the partnership and the gratitude to both the Kennedy Forum and the American Medical Association, Enternology, and countless others in bringing this to fruition. Nathaniel, I think the thing that brought us to the work was kind of two elements. One, I think you gave a really good description of, which is just we have access now to resources and data that we did not have access to, even as recently as 2 or 3 years ago. One of the incredible things that's happened in the last 3 years has been the availability of these transparency files, which Nathaniel, as you remarked, have so for every commercial network and every NPI in the country, and then every in-network code that's contracted, there's a JSON file that sits out there somewhere in the internet's ether, and it's updated every 30 days. And they are massive, and they're clunky, and they're hard to work with. But when you can develop mastery of them and then develop the methods to reconcile them with claims data or cost accounting data, or other sources of information, you can just create really powerful insights. And so the advent of that really, I think, is allowing us throughout the industry to be able to leapfrog a quantitative understanding of the field we've never had. And that leads me to the second, because it couldn't have come a moment too soon. We're at a tipping point for our mental health infrastructure across the United States. We've hollowed it out because everybody knows that these payment rates have been asymmetric, and it's been disproportionately in favor of physical health. And that's not to denigrate the importance of physical health, but I think we are all here because we understand the single most important organ in the human body is the brain. And the things that vex the brain are extraordinarily difficult to understand. And it takes men and women spending and devoting large chunks of their life to understanding the science of that and behavior and the evidence-based methods that help individuals overcome isolationism, anxiety, depression, serious mental health disorders, addiction, and so on and so forth. So there is this incredible opportunity right now, not just in mental health, but for the broader American healthcare system, to start rebuilding this infrastructure. And that takes economics and capital, and it takes an understanding of both the altruism and the social importance, but the economic case that can be made for that. So we believe this is a tool, a method, an approach that it's in its infancy today, but that as we grow its utility, its application, its breadth, its coverage, it has the potential to be a powerful catalyst for how we underwrite and capitalize resources across the U.S.
Thank you so much, David. And I'll turn to you, Chris.
Thank you so much, and thank you, Nathaniel, David, Greg, Kennedy Forum, others for having us as part of this partnership. When David came to us, almost it feels like almost 2 years ago, as having this conversation, I think we were really excited to be part of this solution. You know, the laws that Congressman Kennedy mentioned, right, went into effect in 2008. And I think since then, right, there's been a lot of pointing fingers and discussions about how to then put that into action and create change in the environment. And unfortunately, I think for those folks that work in this space, the environment from 2008 to today is not that much drastically different than when it was at that time. And I think there's a lot of reasons for that. And that's where we're excited about this potential around utilizing these MERF files, transparency files, to start changing the conversation rather than a bunch of pointing fingers. Let's just all just work off of the same playbook and have the same conversation and start working towards action. I think one thing that kind of underpins this, I help lead our behavioral health integration collaborative, and there are integration codes that were specifically designed to be physical health categorized instead of behavioral health categorized. And guess why? Because it was seen as being less burdensome on practices than if it was categorized otherwise. That just underpins the difficulties that those folks that are trying to serve their patients and trying to get them the types of support they need. And you shouldn't need that separation of categorization to be able to provide the type of whole person care I think we're all striving for. And I think having this type of data transparently agreed upon in the ecosystem really just changes the dynamic of the conversations and starts, rather than trying to figure out where there's issues, start to moving towards action. And so really excited to see how we can move this conversation forward because there are folks that are painfully seeking support. And the more time we take just having conversations, the more impact it has on the getting the care that they need. So really looking forward to the type of impact that these types of tools can have in terms of moving the needle forward in this space.
Thanks so much, Chris. And speaking of impact, I wanted to ask, so for next question, how you see people using this tool in their day-to-day work. I know everybody's checking it out. We have lots of good questions. I want to go from just like a page they check out to their home screen. And so the question is like, how do we see people using this day to day? And maybe I'll start with you all at Third Horizons.
Sure. The parity is complicated. American insurance is complicated. Uh, Navigating healthcare landscape is complicated and fragmented. So I think at the end of the day, certainly sophisticated advocates, we can see, using these tools to try to, either they want to buy the best insurance on their individual exchange, or encourage their employer to buy the insurance product in their state that has the best parity rankings in the index. I think primarily where we see the most utility is for those that don't know, almost 60% of the commercial insurance market is driven by self-funded employers. What that means is that the employer community is fully at risk for the health plan. And so it's all their dollars. It's not the insurance company's dollars. They are managing the dollars, but it's the employer's burden to distribute those dollars on behalf of their employees in a way that improves their health. And if I'm a large employer and I sponsor a health plan, and my employees are coming to me saying, my son, my daughter, myself, like, I went and had a baby, I went and had knee surgery. It cost me $500. It cost me $50. It cost me $1,000. My son, my daughter, myself, I needed to go to mental health treatment or substance use treatment. I had to come up with $10,000. I had to come up with $7,000. That, in its face is confounding to an employer who's paying a lot of money, probably 15 to 20% of their overhead for their employees' healthcare costs. And so we think that that is a primary use case in how they select which insurance product they choose to manage their beneficiaries with. We also, imagine that the health plans themselves, largely these MRF files are so big that there are organizations out there who may have never even looked at their health plan at this kind of macro lens that we're presenting today. Large Fortune 10 companies that are analyzed here that have so many departments and so many silos within their organizations that perhaps they've never even if they've had the data internally to look at it this way, perhaps they've never even presented or attempted to look at it across those silos in this way because they have different departments that handle social workers and drug and alcohol counselors and facilities and physical health. So that's just a couple use cases. I'm sure Chris and David have a few other use cases.
I'll add on to that. I think the power of this is we've all been in the dark for so long with respect to what the economics look like in this field at scale, that we've kind of just we've lived anecdotally, right? That you can think back as recently as the ProPublica piece that was put out earlier this year. It talked about psychologists and others who have exited taking insurance and have gone just to pure cash pay systems because the system, the insurance mechanism, which is the primary mechanism through which we've underwritten these services across the board for decades, isn't adequate to keep them whole, right? We've known those things anecdotally. But what this tool and the methods behind it does is it kind of shines this bright light across the country and shows just how big and pervasive that gap is, both in terms of coverage and reimbursement. And I can think of dozens of different use cases. The ones that are, I think, most prescient to me are, our ability to regulate. So on the call today in the audience is Representative Lindsay LaPointe, who's one of the staunchest mental health advocates you'll find in a legislature anywhere. We have the privilege of having her in Illinois. So as she's thinking about the role of the state and regulators and how we drive forward parity, we hope things like this, methods like this, the framework can be a useful tool in our state and other states across the country, perhaps even the federal government as they're rethinking their approach to parity. The other thing is it's really easy to look at this tool and point the finger at payers and say, well, this is all the payers' fault. And this may be a little bit unpopular to say, but like everybody else in our industry, payers, the delivery system, clinicians, and the like, everybody kind of just they play to the rules of the system we've developed. And the point is, we've got crappy rules that have governed our system for a long time. We don't have a way to measure them, we don't have a way to enforce them, and everybody plays to that. We also know payers are becoming increasingly aware of the correlation between behavioral health and physical health outcomes. That is an embedded incentive. So, to what degree can we help payers close these gaps, both in terms of who is in network and how they're reimbursed? The prevention, an ounce of prevention is worth a pound of the cure. We know in the US, $5 trillion annual spend that's being driven by chronic disease prevalence, which itself is correlated with behavior, can be stemmed by making a bigger and bigger investment in mental health and addiction. We're a big step closer in being able to quantify a business case for that. So how do we help payers to better understand that and implement processes, policies, workflows, and the like to make that better? And then how do we help the field really understand how they're being paid on a relative basis so they can prosecute a case for the tremendous value that they bring for patients struggling with mental health disorders?
And really quick before I turn to you, Chris, I mean, one sort of like immediate use case that came out of what you just shared too is in the federal government's report to Congress on parity implementation, they actually have like a whole vignette where they did like parity and reimbursement with one of the carriers. But sort of probably what literally happened, I think this was in the self-funded employer market, is they sent a letter to the employer asking them to do this kind of parity analysis on the reimbursement rate, and the employer sends it to their third-party administrator. The third-party administrator has to like figure out a whole protocol by which to do this, and then send it, and then they have to interpret it. And so the incredible thing here is like this is already done. We use the transparency and coverage data to do the entire end-to-end process that both parties can look at. And, maybe not if they disagree, you can have like a sort of concrete methodological conversation about the data other than this like attenuated, and everybody can save time, energy, and live longer. So hopefully this
Yeah.
a lot of
And Nathaniel, let me just double click on that quickly before Chris jumps in. The ability to slice and create different views of this data is profound. You can look at these rates at the NPI level, across other NPIs and across other networks, and get a crystal clear triangulation on what those rates look like, facility by facility, practitioner by practitioner. This is kind of a macro view of that as we think about the economics of a geography in the industry. But the ability to get to those answers faster, better, cheaper, it's never been better.
Yeah, I mean, I think you took the words right out of my mouth, David, right? The core of these transparency files added was the democratization of this data. Now, right, it went into effect in 2022, and now we're just getting the ability to actually make that information actionable. But it really changes the conversations that's happening across the board. And I think you can name every single stakeholder in the healthcare system, and you can find a use case where this could apply from the provider side and their negotiations with payers, from the patient side to better understand how their different insurance carriers are actually providing this type of services. But I think at the end of the day, we were talking about this the other day. It's really how do we change this ecosystem to make it easier for patients when they plug into it, when they need it, how they need it. It's very simple, but it really takes a lot of this conversation. And, there's a lot of conversation this administration about waste, right? I think there's been a lot of waste at the state levels, at other levels of how to evaluate this conversation. What is the reasoning? And a lot of energy going into that rather than making changes. And I think now we have the ability to stop talking past each other and actually have a common ground to have productive conversations to how to move things forward. I think there's a lot more alignment across a lot of these stakeholder groups to really want to have this type of timely access to whole person care. It's how we get there. There's some disagreement. I think this type of data really allows us to have more productive conversations that ultimately benefit the patients that are trying to access this care when they need it, how they need it, wherever they touch the healthcare system. And I think that's where this type of information can really move the needle. So we're not having the same conversation 5 years from now, 10 years from now, like we've done up to this point in time.
Absolutely. One other thing, even I was thinking on the alignment front, is before this transparency data came out, like even if, let's say, provide payers wanted to work together, providers wanted to work together to work on anything about fairness and reimbursement, you could only talk in the highest of level of generality before it becomes like antitrust violation. Like even if everybody wanted to get together and be like, we want to see what fair reimbursement looks like, you would have been violating the law. And so like there was sort of like it was no table by which to even have these like good faith alignment conversations because you had to keep all your cards close. And so I think the incredible thing here is like now it's like all in the open. Like people can see like this is how much my colleagues are getting paid here at this other system over with this other payer. This is how much my like, partner carrier is paying for the services. And so now we like have the table set, I think, to make those conversations much more detailed and meaningful as well. And I'm also looking at the time. I put together a lot of moderation questions, and we have a lot of good Q&A questions. So let me, I'll, maybe like one more good one, and then we'll turn to Q&A. Um, so maybe we'll make it like a twofer. So uh, we have we sort of alluded to some of the recent policy changes, and then we also know that the administration is planning additional work on revising the 2024 Parity Final Rule. And then there's also a lot of action happening in the States. And so I was hoping to hear, and then we just kind of talked through like all the different like private opportunities too, as different folks respond to this. I was hoping to get your thoughts of from both like sort of a public policy perspective on a federal and state level, and then sort of like a private ordering perspective. How do you hope that people sort of like carry forward this tool as we think about working towards national expansion and scale up? Um, and how do you hope to see different folks kind of respond now that this is out there in the marketplace? I'll try to.
Yeah,
Yeah.
well, and I'll jump in. I think, we published it open source, with a nonprofit, with our nonprofit partners here, by design, right? Like we want to make this as smart and as inclusive as possible. There's a code book if you want to download the Excel and run the methodology on it yourself. If you dare to download a MRF file and play with it, or certainly reach out. We're happy to give you different views or what have you. I think you know Patrick mentioned at the beginning, like I'm deep in this space for decades, and just to be transparent, like NQTLs still confuse me. And I'm pretty close to this stuff. And the non-quantitative treatment limits thing has been really, really hard um, to navigate a regulatory and a measurement-based approach to solving some of our parity challenges, getting to the medical management question, getting to some of the other questions or other challenges that we have, or the ghost network issues, or all of this. There's lots of deep end of the pool issues that I think we struggle with around parity. Um, but if we look at the big picture around uh, in-network status and reimbursement rates, right? Like we have a workforce crisis. Um, you know, People are going into physical therapy. People are going to become X-ray techs and ultrasound techs, um, partly because they can make more money. Registered nurses, they can make more money. Like it is hard to convince people to become social workers, drug and alcohol counselors, psychiatrists when their peers are making more money. That is just capitalism, and that is the country we live in. And so I think we just have to be really honest about that. And if we have a workforce shortage, part of that is our inability to pay mental health and substance use providers more to do this really important life-saving work. And so we have to get at rates, and we just have to get at rates. And I think the network composition issue, um, when compared and correlated to our reimbursement rate indices, start to illuminate that picture a little bit and point you in that direction. And so to answer your question, I think whether it be at the state level, the federal level, or at the employer or the insurance plan level, I think really taking a hard, steely-eyed look at, is this a simple quantitative method here that isn't perfect? It doesn't solve all the issues, but can get us much further, much faster, as Chris said, and isn't actionable. And we're still going to have to navigate all the other issues that still sit in the NQTL space. Um, but could this advance the ball really fast, really quickly, and create a level playing field for measurement based assessments?
And I'll just add, obviously, we at the AMA we're supportive of the 2024 final rule and would love to have that put in place. That said, I think there's a lot of opportunities at the state level, right, to be able to codify a lot of these efforts, to be able to utilize some of this information at that elements. And I know we're doing a lot of work in those spaces to be able to make those a reality. So there's a lot of underplay. I think there's a lot of conversations that happen at the federal level, but understanding there's a lot of impact that these regulations have at the state level to be able to facilitate the type of care we're talking about here too. So I think that's the benefit, right, of starting the pilot in Illinois. It looks at both of those lenses, and I think there's opportunities to then spread those types of efforts to other states. So it's not. So there's opportunities no matter what state you're living in, you have those types of protections.
Thank you so much. And maybe we should try to get to the Q&A questions, unless we have any other parting thoughts. Because I'll just say one of the most consistent questions I just see is, what is our plan to sort of to expand? And so our goal is to expand nationally as quickly as possible. And so I think one clear call to action for people, we saw some specific states that are interested and excited. Please do connect with us. You can respond to the email that sent the webinar link, or info@Kennedy Forum, because we're looking for states and national partners to sort of expand this further, so that we can touch a lot of these dynamics. Um, And because we want to make this a stakeholder engaged process. And so if you find specific use cases that are helpful, if you find states that are helpful, please reach out to us as we're looking to expand. And then maybe I'll take on some of these questions.
Nathaniel, while you're taking on one of those others, I'll jump in quickly. Our initial plan on this was to kind of go state by state, region by region over the course of an 18 to 24 month period to get this built out nationally. What we kind of came to realize a couple months ago is that we've processed this same kind of data across about 9 national networks that really represent a pretty high volume of folks across the country and let us put in a really good foothold. So we're accelerating that. We don't have an exact timeline, but we're looking at months rather than years. And to Nathaniel's point, just like it required a lot of hands to put up the Illinois beta site, we'd love feedback on what you're seeing and folks out there that have things to contribute, resources, subject matter expertise, and the like. More hands make light work. Faster we can get this out. We've got the methods, processors, and data. It's a lot to bring it to fore for the entire country, but we're committed to getting it done in short order.
Thank you so much. And then one just quick question was how often are we doing tool updates? I thought I'd let you at Third Horizon take that one.
Yeah, we're looking to do quarterly refreshes. As David said, they're posted every 30 days, but we're looking forward to trying to refresh the updates quarterly. And one thing that we're excited about now that the data we're looking at is kind of Q1 2025 in Illinois. Once we refresh for like Q2, we hopefully going to be able to add some trending, so you'll be able to see if there's any trending over time or look back in history. So we're trying to build that functionality in.
Just one other question we got is where can we find the raw data? So if you just Google the name of any health plan and transparency and coverage, you can find the raw data. You will not be pleased by what you find. And that's sort of like the magnitude of this project is the raw data it needs to be processed in order to be useful. And even then is like quite arcane, unfortunately.
Yeah, the tool does allow you to export the data that sits in the tables, and as we grow the tool, we'll grow the volume of data, which will grow the robustness of what you'll be able to export. If you have a background in data science and you know how to work with JSON files, to Nathaniel's point, have a lot of fun. They're powerful files, and if you've got some background on that, you'll be able to tame them, I suspect. For most of us, though, using a tool like this and then the exports will get you what you need because the data's gone through the methodology process that Nathaniel referenced earlier.
We also received a lot of different questions about sort of like subviews, like are certain services or professional types like moving up and down the average? Have we been able to look at like pediatrics versus adult? And then maybe we can come back to the residential treatment center or freestanding psych facility question too, which we received some questions about. But I don't know if you wanted to speak to that.
Yeah, I mean, we didn't talk a lot about it today. We talked a lot about provider NPI and facility NPI. The core of this is actually built on provider taxonomy and provider taxonomy type. And so when you look at the Excel, you can kind of see the different provider types. And so we're really looking forward to expanding the views around different provider taxonomies and being able to sort between licensed clinical social workers and physical therapists and all the like, and every other cross section of a provider specialty you could want to look at. So how fast we're able to surface that for end users, I'm not so sure, but you know, the feasibility and the utility to do so is there. You could give us any combination of provider types today, and we could run an analysis and export you a you know, the rates and the network composition for those provider types.
I'll just quickly add, we did use claims data to create a weighting system within those taxonomical fields. So, you know, if you do have an opportunity to look at the methodology document, it will really kind of lay that out there. There's a richness and a robustness to that. Just like the expansion to the other 49 states, we also understand there's a whole different litany of views people will want to see, and we are prepared and willing and excited to build out that functionality. We're eager to know what the best applications of that are, and then co-development partners that can help us bring that to light. There's a lot we can do with this, as we've been telling ourselves we're at the top of the first inning on this. There's a lot more we can do together.
And maybe I'll just address one last question and then maybe do like take a second to think like a lightning round, last thoughts for this group. Um, One person asked about sort of like whether and the extent to which it's able to take into account administrative burden that might keep people out of networks and outside of sort of other dynamics. And so I think one of the challenges we face is that right now the transparency and coverage data only does cover sort of the negotiated rate and allowable rates. And so we don't have that much insight at the moment into a lot of other dynamics that might affect um, empanelment issues and like sort of like administrative burden. So I think it's also a little bit tethered to the future of transparency and coverage as well, where some of these analyses can go.
Yeah, so that was when Greg was talking about creating more increased payment rates. I think the thing that I was going to chime in for was that the administrative burden is also a huge component of creating an equal playing field. I'll say, if we could simplify the conversations where some of these other elements are starting to get more equally weighted, then you can start diving into some of these other pieces. They're just such large issues right now that it's hard to get at some of those other unknowns because there's such big chasms as the data shows and the index, right? And just in terms of some of these other elements. But it's definitely something we talk a lot about on our end, and we hear a lot from our members.
Thanks so much. Would you want to start us off on closing us out with lightning round, Chris? Any parting thought for our wonderful group?
I mean, our key conversation we always have internally is how do you make the right thing to do easier? And I think that at its core is what this index is trying to really address. I think there's been a lot of, again, conversations, efforts put into how do you evaluate some of these things. And the goal right here is to just remove all that energy and start putting it into productive movement for the type of care and healthcare system I think we're all striving to have. And I think the abilities and the great work that Greg and David and you all have done around this effort, I think is really going to exponentially change the discourse in the environment and get us closer to where we're all striving to get to. So really looking forward to expanding this out to other areas and appreciate you all including us as part of this fantastic work.
We really appreciate your partnership. David, last thought.
We want floodlights on across the country on these rates and network participation and all the other things that flow from that. Sunlight is the best disinfectant, as is said, and the more entities, the more stakeholders, the more people we can democratize this information to and for, the better decision making we can have across the industry, and we can start reversing what has been a decades-long trend of divestiture to investment that can have a profound intergenerational impact. This is maybe mental health and addiction. This is maybe the most important public health-centered area you can conceive of for our nation. And the stuff we're talking a bit about today is pretty seminal to that. So, Nathaniel, thanks for putting this together, and thanks to everybody for joining.
Last thought, Greg. We have like 1 second left.
Well, mental health and addiction doesn't cost money; it saves money. In my own life, I've been paying into the insurance market since I got addiction treatment, 24 years ago, and I think I've invested about $120,000 into the insurance risk pool since my recovery. And so I think we have to remember how much investment in mental health and substance use can pay back our health system, and it's unsustainable. Our costs are unsustainable, and we need to start to invest in ways that are going to reduce costs.
Well, thank you so much to the three of you for participating. Thank you so much generally to Third Horizons, the AMA, Internology, and all of you for being a part of this. Please do reach out for opportunities for collaboration if you need help with the tool, but we're really excited for next steps and working with all of you to make parity a reality in the nation. Thank you so much, everyone.
Thank you.